doctors that I work with or got to see patients with, so thank you for having us. As Dr. Okura said, we're coming to exchange ideas, and I'm sure I'm going to learn more about surgery by coming here than I did before I came. So thank you for having us. Pick our brains. We'd love to exchange ideas, and any question, you know, try our best to answer it if we have an answer. If not, we'll just tell you I don't know. What I wanted to talk to you today about, I didn't really know what you wanted to hear, so I put something together, what's called acute care surgery, which sort of shows you how we do things in the U.S. We combine trauma, emergent general surgery, and critical care, and so that's what I do. I do those three things, and one week I may do just emergent general surgery, the next week trauma, and the next week critical care. So I go through my rotation, and I really like the variety. And so we've called that specialty acute care surgery, and that's how we train our surgeons, our young surgeons, if they want a career in that. So I'm going to go through a few things, and I know we have limited time, so I may have to cut things a little short. I'm sort of watching the clock here to be respectful of your time, but we'll get started. If you want to ask a question, I've got some slides in here specifically for the surgeons. So if I show you a gunshot wound to the pancreas, you want to talk about it, while I've got the slide up, just interrupt me. I'm very approachable. So just say, what are you talking about there? What are you trying to say? So I wanted to just, for me and Dr. Blackwood together, just so you may know where we're from. This is the state of Georgia. You can see, there it is. You can see Atlanta right here is the biggest city, and then Macon, Georgia is right here. Atlanta has about 6-7 million people in it. Macon, Georgia is about 170,000 to give you an idea of where we practice. This is the campus that I practice on. It's a block. All those different buildings are the Children's Hospital, the Cancer Center, the hospital or trauma center. So everything is sort of packed into that one big block area. And just to tell you about our hospital very quickly so you know where we come from. 600-bed hospital. We're a level 1 trauma center, which means we're the tertiary, we're the referral center. So I get patients from 100 miles away that are trauma patients. Dr. Blackwood, when he was there, he's now in Atlanta, but he would get patients, kidney failure patients needing dialysis from many, many miles away. So we're sort of the hub, if you will, for that whole southern part of the state. We do have training programs, like I got to meet some great young doctors yesterday that are training. We have programs, as you see here, in general surgery, pediatrics. That's how I met Dr. Okura, family practice, internal medicine, and OBGYN. So sort of the core residencies, if you will. And our medical school we're associated with is Mercer University School of Medicine, which our primary goal is to put doctors in rural Georgia, because we have a lot of areas that are very rural and really don't have doctors. So acute care surgery, as I said, is made of trauma, emergent general surgery, and critical care. I'll take trauma first. It's my favorite. And there's no way I can cover all of trauma in just a few minutes, but I wanted to talk about something that we've been doing over the last several years that's fairly new to trauma surgery, and that's dealing with rib fractures. Now, when I was a resident, like some of the young doctors in the audience, the way I managed rib fractures were pain medicine, some oxygen, and just tell the patient that things would get better over time. But they have a lot of problems. You see this 3D reconstruction CAT scan there on the flail chest. When they're really bad, they cause a lot of respiratory problems, and those patients really, really struggle sometimes for months. Some of them never make it back to work. So we had to come up with a better way to treat these really complex chest wall fractures. And we've come a long way. In the early stages, this is back in the 1950s or so, you can see this poor guy, they put him in a splint for the chest. My orthopedic colleagues may be laughing at that. It's sort of funny. That went away before I came along, but they would put him in a splint, and obviously that helped with pain, but everybody got pneumonia and atelectasis, and that really didn't work. Then there were some more creative ways where we would actually hook, and I'm talking specifically about flail chest now, so where they would actually put these various devices in, clip them into the, like that's a towel clip there, into the skin, and suspend it with traction, trying to pull the chest up. Again, the old days. And you can see, again, some more different devices. There's a suction cup at the top there that they actually stick on the chest and hook that to a rope and hang it over the bed, the traction, and pull the chest up. Or again, put these metal bars through the chest and pull that chest wall up to try and stabilize it. But then things started to change. This is about 1956. See a new method of treatment with continuous mechanical hyperventilation to produce alcolytic apnea and internal pneumatic stabilization. So that's a mouthful. What are they talking about? And I'll show you what I mean by that in just a second with a picture. This was the first case they used to treat, again, 1956. This was a man, 51-year-old, suffered injuries when he was crushed into an 8-inch space between a railroad locomotive and a furnace. So he had tremendous chest compression and crushed chest. And so what they did was put the stainless steel bars here through the chest wall, which gave him a place to anchor, and put the gentleman in traction. And this actually worked, but you can imagine laying like that for 2 weeks until the ribs start to seal or form callus. Not a great way to do it, but that's all we had. And then these patients had to be put on a ventilator. This is one of the first ventilators, the Morch ventilator. You can see it's a single piston ventilator, not very sophisticated, but it did the job. And you can see this man's fate: bilateral chest injuries, bilateral suspension with traction, and a ventilator for 2 or 3 weeks until they could take him off the vent and the chest had healed, or at least form callus. So obviously we've gone way away from that. I just give you that for historical perspective. But on your left, this is a 3D reconstruction CAT scan, and you can see how bad that chest looks. The segments are free floating, and that chest wall is just not going to function very well. The X-ray below, you can see here, but the chest is really not coming together. You've got this lateral chest wall and obviously pulmonary contusion. On the right, you see again just another. That's not a flailed chest, but you can see multiple rib fractures that are displaced on one side. And again, you can see the deformity in the right chest. It's not symmetrical with the left. So these patients really, really struggle to breathe and have a lot of problems long term. Oh. There we go. So, when I'm talking about a flail chest, I'm talking about 2 or 3 ribs, contiguous ribs, broken in 2 or more places, so that the chest wall actually floats. I take a breath out, and the chest wall actually falls in, and vice versa. So it really doesn't lead to good ventilation and oxygenation. And then the mortality of that alone is 10 to 15%. And in the 70s, it was up as high as 80%. So we've improved a lot. It's not that high for us now. It's probably at our center, it's probably less than 10%. So we came up with surgery for this to treat it, following some of the principles from our orthopedic colleagues. You can see if I were going to deal with a flail chest, this gentleman has a flail chest on the right side, so he's placed in the left lateral thoracotomy position. Arms are extended like this, exposing the whole right side of the chest. And you can see that the table is broken there from the head and from the feet, so that you can open. Some people are really sort of short and tiny. You really need to open up that space. But I would say in most patients, we do them just on a flat table. We don't have to do that, but you can. And you can see the patient position here. He had a chest tube. At the bottom picture, there's a hole in the chest. That's where he had his chest tube. We've taken that out. And now I have access to the whole chest, the right chest. Notice how all the bruising on the arm and the chest wall, as you do more of these cases and operate and get in and plate the ribs, it's tremendous what you see, how much bruising and contusion there are in those muscles. This just shows you another gentleman. This is not really a flail segment, but this, you see on the right, you can see all the fractures. So almost every rib on the right side is fractured. And what we'll do is go in and plate those ribs with plates and screws, titanium plates, and stabilize the ribs. And this just shows you what it looks like. Again, you can see here, patient's head is here, feet are here. Again, the patient is laying in this position, and you can see the overlap of the whole chest. Well, that whole chest is fractured. All those ribs are fractured, and they've come over each other like this. So what we do is use rib reducers where we grab the ribs, pull them back, line them up, and then we will plate across those ribs. And you can just see this gentleman had so many fractures. This was a flail segment here, so I had to make an incision anteriorly, take down the serratus muscles a little bit, and then a posterior incision as well. And once you get under the serratus muscles there, take down 2 or 3 of those, you can really put your hand on the chest wall and really go all over the chest. And you can see I've demonstrated that here by elevating that muscle flap, okay? And then that's what the final product looks like. You can see we've got 1, 2, 3, 4, 5, 6 plates on this patient. Now the ribs are lined up. It's respiratory wise, it's very functional. Now the whole chest wall moves together in harmony. And the amount of pain that they have after this, it really falls off. It's really a tremendous improvement. I've had patients come back and they wake up, they get off the ventilator, and it's just a tremendous improvement in their pain. When we first started this, I've made big incisions, and as we've gotten better at it, now we do small incisions. I have fairly small hands. I can get in a 6.5 glove. I typically wear 7, so not real big hands. And you can see, if you look at my hand on the next slide there, you can see the incisions are getting smaller. We call them keyhole incisions, and I'll make a couple, and I can wander around the chest there and get my plates in. And here you can see my hand there, not very big, and that just shows you the size of the incision. So another thing that we learned that these patients, even though they've had a chest tube in, they still retain some hemothoraces. And so my partner, Dr. Christie, did a study and published a paper looking at when we do these patients, they're asleep, we'll put a scope in and look around, put the lung down, and then you can see the lung on the left is down, and see that blood that's still left in the chest cavity, and we'll go in and suck that blood out. And what he found was the length of stay is shorter in the ICU as well as the floor, and we get the chest tubes out quicker because they don't drain anything. So this was a big improvement for us as well. And I was going to show you a video, but it's not working for some reason. When I loaded it over on my computer, it quit working. But I was going to show you this gentleman. You see his posterior incision there. You have to worry about not taking out the thoracodorsal or the long thoracic nerves. And when I had my hand in that bundle, those were protected in the muscle bundles. And I was going to demonstrate that his scapula still works. It's intact. As I had him do push-ups against the wall, you could see that his scapulae were still functioning properly and didn't have a wing scapula. Okay, so now changing gears a little bit, gunshot wounds. Unfortunately, we get a lot of those in the U.S., so we've gotten pretty good at it. You can see this gentleman here. This is the C-loop of the duodenum. You can see pancreas here, stomach's right up there, and the C-loop coming around here. So sort of like the start of the third portion of the duodenum, through and through wound there. It looks pretty bad, but after you debride that wound a little bit, actually connect the two holes, it was through and through. It really wasn't that bad. So we did a two-layer closure with vicals, and for the surgeons, general surgeons in the room, and then with silk sutures. You can see the pancreas to the right there of my sutures. It looks good. The pancreas is, so with the pancreas not being involved, we did not do a pyloric exclusion. We just did a primary repair. This gentleman's a little bit different, 20-year-old male, gunshot wound in the right upper quadrant, arrived at the trauma bay, somewhat lethargic, GCS was 12, heart rate 107, blood pressure's 98, he's diaphoretic, so he's obviously in shock. Now this gentleman had a little bit more complicated case. You can see this is through and through the duodenum again, but now this is the pancreas, and there's blast effect. The bullet came right by the pancreas here, or right through the edge of the pancreas. And here, the ampulla vater is very close to that gunshot wound, so we needed to make sure the biliary tree was okay, because that would totally change the operation we're going to do. So what we did, you can see the gallbladder pulled up here. We've taken the gallbladder down. That's going to come out. It was injured as well. But we placed a catheter, a foveated catheter, or a red rubber cath. This is actually a foveated down through the cystic duct, into the common duct, and out the ampulla vater, which helped us identify the biliary tree, and it looked okay. So once we knew that, we knew what operation to do. And you can see here, the sutures in place there, repaired it very similarly to the last patient. But this time, with the pancreas being involved and worried about pancreatic juices bathing our sutures, we did a pyloric exclusion, which is where we isolate the pylorus, and I'll show you that in just a second. Make an incision in the bottom part of the stomach, just like you were going to do a gastrojejunostomy, and then go down there, grab the pylorus, pull it up, use usually a 0 proline, and a non-absorbable suture, and then run it to where the pylorus goes from round to flat like that, linear, and just run it back and forth, and then do a gastrojejunostomy. So what that does is then divert the gastric juice away from the duodenum and the pancreas there, while my complex pancreaticoduodenal injury heals. Now, what about blunt spleens? We get a lot of these as well from car wrecks and motor scooters and people falling off the roof. You can see here, this patient was a 45-year-old male. This was he struck, means that's just shorthand for us for pedestrian struck by a motor vehicle. Blood pressure looks good, heart rate's a little tacky there. Hematocrit is okay. And you can see they had a really large blush here of contrast in the spleen. So he has an active bleed. Two ways that we would manage that. Typically, we used to take all those spleens out and just do a splenectomy or a splenorrhaphy. And now, what we've done, this patient's stable enough. Our vascular team is fast enough. Our either interventional radiology or vascular team in the U.S., either team can do that. They can go to the vascular lab and they can do embolization of the splenic vessels and stop that bleeding and not have to have surgery. We've got the time down now to less than an hour. We run around about 50 minutes or so to get them, if we really ring the bell and say this is emergency and we have to go. It's pretty stressful for the team to work that quick, but we've managed to be able to do that. If they're unstable at all, we'll just go straight to the operating room and we'll take the spleen out. So we have a couple of options there. And then for blunt aortic injury, again, when I was a resident, these were all managed with huge thoracotomies and replacing the thoracic aorta. And now our vascular colleagues have gotten very good at putting a stent up here, just like for cardiac stenting. And you can see here's the aorta, and you see this little line right here and this little blurb. That's a false lumen. So the aorta has torn from the blunt force, from hitting the steering wheel or hitting a tree, or just from going from real fast to stopping very quickly. The aorta just tears, usually just distal to the left subclavian. because of the ligamentum arteriosum, and now they can put in a stent going through the groin and no big thoracotomy. So this has been a game changer for us. These are not real common injuries, but they can be catastrophic when they happen. And then brain, I'm not a neurosurgeon, but we do, all the brain injury patients are admitted to our service, the acute care surgery service. And so we won't operate on the brain, our neurosurgeons will, but we'll manage them in the ICU. So maybe ICP monitor to see what the pressures are, 3% saline or 23% saline or mannitol, whichever drug you like to use to try and decrease brain swelling. Obviously ventilator management, so all that is run by our critical care trauma team. So now moving into emergent general surgery. This patient is a 69-year-old female that had a colonoscopy in November of 2011 by our GI team. Had a sigmoid colon intramuscular adenocarcinoma, pretty straightforward, right? But also then an ascending colon tubular adenoma. And the lesions were tattooed so that we could see them as surgeon, where they actually inject an ink into the mucosa. So when I'm looking at the patient's colon in the abdominal cavity, I can actually see the ink, the tattoo, and make sure I get the lesion out when I take out the piece of the colon. And they were recommended surgical referral. But I'm sure that would never happen here, but in sometimes in the US, patients wander off or get lost to follow-up, and they did not come back for quite a while until they came back with dehydration and were very sick, and then we could start taking care of the patient again. And this just shows you can see on the left, this was the tubular adenoma, again in the ascending colon, and then on the right is the sigmoid intramuscular adenocarcinoma. So we're dealing with two lesions. So what we did here, you can see the tattoo marking with the arrow. You can see that hazy blue right through the mucosa, right through the serosa, so we knew we had the lesion. And here's the specimen once we had it out. Extended right hemicolectomy, we got everything out and took care of the patient. And then finally, critical care. Just to briefly touch on this, obviously can't cover all of critical care in just a few minutes. But this patient has ARDS. Fortunately, this disease has gone down since we've learned to manage patients better on the ventilator with lower pressures. We've learned to give less fluids and more blood for trauma. So we've gotten much better at managing our patients physiologically, and the rate of ARDS in our center has really gone down. But the definitions, we still use the American European Consensus Conference statement, where it's acute onset, bilateral infiltrates on chest x-ray, wedge pressure. We don't really use that anymore. We don't float very many swans like we used to. When I was training, we use a lot of ultrasound now to look at the heart and look at the vena cava and see if the volume status is good or bad. Bedside ultrasound has really become a major workhorse for us in the ICU. And then acute lung injury, if the P to F ratio on your blood gas is less than 300, it's acute lung injury. If it's ARDS, P to F ratio less than 200. Pretty standard definitions. The pathogenesis is the alveolar capillary barrier. In other words, the alveoli start weeping, or actually the capillary bed starts weeping, and then that gets into the alveoli. And I've got a good picture on that in a minute to show you what that looks like. The mechanisms are ventilator induced. When I was a resident, again, we would manage patients with 10, 12 cc's or higher of tidal volume per kilo, 10 to 12 cc's per kilo, which was huge. And now you don't see us do that anymore. And what we were doing was really stretching the lungs and cracking the alveoli and really stimulating cytokine production. And so then I get all this inflammation in the chest, and it's no wonder I had ARDS. But we didn't know. We didn't know what we didn't know. And now we realize that lower tidal volumes are better and don't hurt the alveoli. And this just shows you can see the arrow there. This is a electron micrograph of the alveoli. And you can see that big crack. So you can imagine millions and millions of alveoli distended, cracking, and cytokine response in each one. It's not a good milieu for the body. And you can just see here, again, this is beautiful. This is from the New England Journal of Medicine many, many years ago. It's an old picture, but you can see the alveoli is open here and very thin membranes to the capillary, so very good oxygen exchange and CO2 exchange. But here's we get cracked alveoli, alveolar macrophages, neutrophils, all releasing tumor necrosis factor and interleukin, all the other cytokines. You can see that membrane gets very thick, and I cannot oxygenate very well, and we're really having a problem. And so finally here, just to show you again what that looks like post-mortem in angiograms, you can see this beautiful, the big vessels, like a tree, many, many small branches, so great blood supply here. But in ARDS, you can see that disappears. All these little capillaries have clots in them. We don't have as good a blood supply because they're filled with all that debris that we talked about. You can see the alveoli filled with debris here, and you can actually see a neutrophil coming across here and damming up that area. So again, really at the microscopic level, that's how ARDS looks. This is my team here. I'm fortunate enough to have a big team. We're on 24/7 for our hospital, and we just rotate teams in and out. So there's always a surgical, ICU, critical care, trauma team in-house ready to go. As I said, we cover the whole southern part of the state, which is a lot of patients, and really from great distances. So anyway, you've been very kind. I hope that wasn't too long. I'll be happy to take questions or turn it over to Dr. Blackwood, however y'all want to do it. Thank you.
Yes, 5 minutes.
Yes, sir.
Yes, thank you, Professor, for the good presentation. One illustration you gave us there was the duodenal injury. The second from there were two, I think, and the second one, which had a blast injury to the pancreas. So I couldn't grasp it well, how you manage it in the light of the injury to the pancreas.
So
if you can.
Yeah, that's a great question. So I sort of blew by that and didn't give you the full answer, did I? So if you notice that pancreas anteriorly, it was a skive injury, so it was just down, a few millimeters into the pancreas parenchyma or tissue. So the pancreatic duct, the key with dealing with the pancreas is knowing if you know the duct is okay or not okay, as you know. So we felt that the duct was okay because it was so superficial. So we just drained it. I left that out, but before we closed, we drained above and below the pancreas to make sure any juice would come out. When I say drains, what we typically use is the little bulb syringes, the little bulb drains. They have different names with different companies, but ours is a Blake drain. It's a round drain, comes out the skin and then hooks to a little bulb, just not to the wall suction, but just to the little bulb that's about this big. And when you squeeze it and close the lid, it provides gentle suction until it fills up, and then you pour it out, the juice, and then squeeze it again and put the top in. And that seems to work really well. If the duct is involved, then it's much more complicated. If it's a distal if it's a sort of a middle on over to the tail of the pancreas, we'll do a distal pancreatectomy, probably with a splenectomy and trauma, because I have done distal pancreatectomies and preserved the spleen, but that takes a while. I mean, it's bloody, it's very difficult. Not in trauma, I wouldn't recommend that. I would just do a distal pancreatectomy and splenectomy. I do a staple device. I don't sew anymore. I mean, our staplers are so good now, I'll just staple across the pancreas and it seals the duct. If I can see the pancreatic duct I might put a figure of 8 stitch in it along with the staple, but typically not. And then the most catastrophic, if that had really gone through the head of the pancreas, which is maybe what you're alluding to, and destroyed the ampulla levator or the proximal pancreatic duct there, then I'd probably be left with really the most complicated cases doing a Whipple, because I have to take out the pancreaticoduodenal head. We would probably do that, depending on the blood loss, we would probably take out the section, do damage control, because they're probably going to be hypothermic, coagulopathic at that point, and leave your belly open, take them to ICU for 24 hours or so, and then bring them back and do the completion. I mean, if they're perfectly stable and not having problems, you could do it all at one setting, but it's much more complicated case. Was that?
Yeah, I heard you say like gastrointestinal is some. If I correctly understood it, you did gastrointestinal, something like that.
What's that?
Gastrointestinal.
Oh, so yes. So so to do the pilot on that case, we wanted to. We just wanted to divert the GI contents away from our suture line, because I was worried about the pancreatic juice soaking the suture line and then it not healing and breaking down.
I get it.
So in the first case, I wasn't worried about the pancreas looked pristine. It was just a duodenal injury. So we felt confident that they could eat and we wouldn't have breakdown. The second case, I was worried about that juice, because it's going to leak juice even with my drains and bathe those stitches. We was afraid it wouldn't heal, so that's why we did the pyloric exclusion through, and then I had to do a gastrojejunostomy.
I get it.
Great question. And how would you, you've done as many of these as I have. Would you like to would you do it any differently? Or you have any words of wisdom for me?
Oh, well. I have done maybe one or two. I have not done that kind of thing.
Yeah, they're not very
So
common.
we are not experienced in that line. Yeah, as I said here, your common sense will tell you to do something about it. I don't have the experience to say.
That was one of my first cases after fellowship. I did my residency and then a trauma fellowship, and when I came back to Macon, one of my first cases was this complex case, and a case, not that case, but a case like it. So it's like I'd rather get a case like that farther in my career than the first 6 months. So,
Once you have done it, so.
great question.
You have another question, Mr.
Yes, sir.
Yeah, no, thank you for great presentation. Mine is not a question, just maybe a comment on the diagnosis of ARDS. Because sometimes you find that we don't have luxuries of having ABG all the time. So we use a modified like Kigali criteria to diagnose ARDS. Instead of EF ratio, we use SF ratio.
Oh, okay.
Saturation, yeah, F5 to ratio. As long as we're able to monitor the saturation, we use it to diagnose ARDS.
That's a great idea.
Yeah.
That's a great idea.
Sometimes we use that.
What do you use? What is your cutoff, or when do you say with the SF ratio it's ARDS? Do you have a number?
Yeah, so we categorize as mild, moderate to severe.
Mm-hmm.
If it's above 325,
Oh, okay.
which is normal. But if it's below between 300 to 200, that is mild ARDS. If it's between 200 to 100, that is moderate. Below 100, that is severe ARDS.
Okay, very good.
It's a Kigali criteria. Actually, it was developed based on a resource limited settings.
Very good.
Rather than the PF ratio, because you can diagnose it even at maybe at ER, then you can diagnose it with ARDS and then to see if the patient needs that treatment, especially in ICU.
That's a great way to do it.
Even not necessarily to diagnose it in ICU, even if we were in the ward, even if you are in at ER, you can diagnose ARDS as long as you're able to monitor saturation and estimate FIQ.
Okay, very good. Thank you for sharing that.
It was just an addition.
Let me say something here. Dr. Ashley, or Professor Ashley, was very, very key during the COVID pandemic. He was very key in developing how this was going to be managed, because this was most importantly what was killing the patients during that time, and he was forefront. I remember them running around and trying to figure out how these patients could be managed and their lives saved. Would you like to make some comment on that?
Well, you know, COVID stressed us all, and we didn't know what we were doing, like the whole world. You know, some of our information we get off of Twitter, believe it or not. We'd be in the conference room, and some of the doctors from Italy, we you know, they sort of were on the front line, and we would sort of listen to them, steroids, no steroids, you know, high peak, low peak, all those. And so believe it or not, we were just grabbing, you know, the disease was moving so fast, there was not time to read journals. It was a tweet or just any phone call, anything we could get, which I'm sure you all were doing here too. You know, we were just using any bit of technology we had to find out how to take care of these patients. So it was a very difficult time. I'm glad we're past that now. But, did you all have much COVID here in your ICU and have to deal with those same issues too?
Yeah, we had. So actually, even diagnosis of ARDS was based on actually the Kigali criteria and COVID to try to, because most of the patient problem was the acute respiratory distress syndrome due to the COVID infection. So we had a lot.
Yeah, it was tough. We would.
But not in this ICU.
Pardon?
You see, it was actually, yeah, it's a long story.
Yes, it is a long story. Okay, sure.
All right. Okay.
Thank you, Dr. Ashley. Thank you.
Trying to get it to turn off there.
Where is the young lady that helped us?
I'm just trying to get it again. There it is. There we go. Trying to get it.